So there's been a lot of question, a lot of talk about the use of backboards since the state kind of put out the directive on, on spinal packaging and the use of backboards. So just kind of give a general overview of kind of when to use a backboard and when not to.
I think that this has been lots of confusion with lots of people. But I think, again, from a common sense approach and also looking at the literature, and this is not a new thing. The Nexus, what they call it, Nexus, Nexus criteria were developed in California, where they really did a study. And basically what they looked at and what they found was that a reliable patient, and when I say reliable patient, not under the influence of any mind-altering drugs, alcohol, drugs, not a demented patient, not a psychiatric patient. So a reliable patient with no midline tenderness of their spine, not just the neck, but of the back and thoracic spine too, lower back and thoracic spine. They have no distracting injuries, and that's open to interpretation. But I think, an ankle fracture or a femur fracture, that's certainly a distracting injury. And no neurologic findings, paresthesias, weakness, then I think that you can get by without putting those people on a spine board. And that's what we tried to develop our protocol using was loosely off the Nexus criteria. The American College of Surgeons and the National Association of EMS Physicians actually came out with a joint statement basically outlining the same exact criteria. And that's what we tried to do. The backboards are not a benign piece of equipment. They're uncomfortable, especially on older people. There's some people that will say that within an hour of being on a spine board, they're starting to get some pressure sores and pressure points. And some people have told me, well, that's not EMS's problem. We're not going to be, we're going to put them on a board. We're going to be at the hospital in 10 minutes. That's the hospital's problem. And to some extent that is true. The problem with that is that, as we all know, the EDs are busy, and sometimes they get into the emergency department, and it may take them 20 minutes to get checked in, and then you got to get a CT of the cervical spine or whatever, and they're on that board all of a sudden an hour and a half, and they're 80 years old, and then we're playing catch up trying to manage that pressure area. So I think if people will use that common sense and use that tool that has been developed of reliable patient, no midline tenderness, no distracting injury, and no neurologic findings, numbness, tingling, weak, then I think we can say, those people probably don't need a board. Also, if absent all of that and they're walking around on the scene, they probably don't need a board. So that's a general sort of common sense approach that you can put in your back pocket and think about every time. Those four things.
Mm-hmm.